But what happened to the conditions that were not incentivized? So I've showed you improvements in conditions that were incentivized. What happened to the ones that did not have a financial incentive? And here I want to show you the results of the second study that I'm going to describe, where we took 20 indicators that were incentivized and 23 which were not incentivized, i.e. for conditions that were not included in the QOF, and we chose them because we were able to track those indicators from 2000 through to 2007 in a large electronic database extracted from GP records of 660,000 patients. Now, the results of this study are complex, and I'm only going to show you them in part. But what they broadly show is this, and I'm going to just give you the examples of indicators that relate to things that were measured, because it gives a good example that's representative both of the rest and other studies that have been done in this area. So what we see here is that in the indicators that relate to measurement, they were improving before QOF came along. There was a small increase in the rate of improvement and then plateauing. So this is very similar to the previous slide that I showed you. Now what if we take the unincentivized indicators? These are then on the red line. And what you can see here is that there is slower improvement overall and broadly not much change. So I think that you could say that the incentives that were applied to other indicators didn't have very much effect on the unincentivized. They didn't get worse, but neither was there a halo effect where everything got better. And I think that's probably fairly consistent with the other evidence, not very much effect on other conditions. Well, all these are process measures. Do we have any data on outcomes? Have we got anything harder to look at? And we decided to look at, now that we have several years of data, emergency admissions for so-called ambulatory care sensitive conditions. These are conditions which in principle could be avoidable by good primary care. And what we did was we compared emergency admissions for conditions that were incentivized and ambulatory care conditions that were not incentivized. And we looked at 9 years' data for all 8,500 practices in England, and we compared 4 years before the Quality and Outcomes Framework with 5 years after. Oh, I'm not sure we need this slide. So we had 48 disease codes which were incentivized, and there were 500,000 emergency admissions for those in our data set. And then we took 197 disease codes which were not incentivized in any sense, and there were around 300,000 of those in our data set. So this is what we found. The red line shows the rates of admission for incentivized conditions, and the blue line shows the rate of emergency admissions for non-incentivized. And it will be clearer if I show you the difference in differences analysis that shows you how the two groups compared. And what you can see there is that there appears to be a reduction of between 6 and 7% in admissions in the incentivized group. Now, there's a real question, and that occurred coincident with the introduction of the financial incentives. So within 2 years of the introduction of the financial incentives, there was a 6% reduction in admissions for conditions that were incentivized. Now, these data are very new. We've not completely finished analyzing them. I'm not even completely sure I believe them. But this is our first and our hardest evidence of improved outcomes as a result of the financial incentives. My fourth question in relation to clinical care is what happens if you take incentives for indicators away? And here I want to show you some data from a study which Helen Lester did using data from Kaiser Permanente. And we used data from Kaiser because we actually looked everywhere in the world to find a healthcare system where quality was measured continuously while incentives were both put in and then taken out again. And we found a data set with Kaiser, and these are Helen's data. So this is the percentage of adults screened for diabetic retinopathy. And what you can see here is that when the incentive was on, quality was slowly improving, and when the incentive was taken off, the open circles, quality went back down again. And here's a second slide from Helen's data. This is the percentage of women screened for cervical cancer. The filled dots in the first two, quality of care was slowly improving. It got worse again without the incentive, and when the incentive came back in, it went back up again. So that's a little bit disturbing, because it suggests that maybe you need to keep the financial incentives going, because the alternative principle, of course, is that the good care simply becomes routinized and no longer needs to be incentivized. So if I summarize the impact on the clinical care before I go on to the next part of the talk, I think incentives clearly had an effect in improving quality of care in a context where care was already improving rapidly, and probably had a greater effect in neglected clinical areas which were not already improving. But financial incentives were certainly not a magic bullet and need to be seen alongside a range of other quality improvement measures. And I think it's not clear whether and when incentives need to be maintained in order to maintain quality. So that's what I'm going to say about clinical care. Now I want to go on to some other effects. And first is, what happened to inequalities? Now, there is concern with financial incentive scheme that they will make health inequalities worse. And the reason for that is very simple, that practices in affluent areas with compliant patients will find it easier to hit the quality targets. And therefore, there will be an effect in increasing inequality. So is that what happened in the UK? Well, the answer is no. On this slide, we've shown you for the first 3 years of the Quality and Outcomes Framework, that's year 1, this is year 2 in the middle, and year 3 on the right, the scores of practices in the 5 deprivation quintiles in England. These data from all practices in England. So in year 1, these are the most affluent practices, and their scores are slightly higher than those in the most deprived practices by 4%. But by only the 3rd year, there's only a 0.5% difference between the most affluent practices and the most deprived practices. So in other words, the impact of the Quality and Outcomes Framework has actually been to reduce inequalities in the delivery of care. So somehow the practices in deprived areas have done really well and caught up very quickly. Now, I told you that doctors could exclude patients before, so maybe the practices and the doctors working in the deprived areas just excluded all their patients, and that's how they got the good scores. Well, they didn't. These are the reasons that they could exclude them that I showed you before. I thought I had a difference. Sorry, did I go over one? Ooh, I'm out. Oh, that's better. I think I'm now back in the right place. Yes, I skipped over it. Okay. Yeah, this is just a scatter plot of exception reporting rates against deprivation. Again, for all 8,500 practices in England. And the regression line through it, which is the red line, shows that, yes, in very deprived practices on the right-hand side of the graph, there is more exception reporting than on the left, but not much. It's pretty flat. So, broadly speaking, practices in deprived areas didn't get their high scores by excluding lots of patients. Okay, so now we get on to unintended consequences. I've showed you some quite good things so far. Clinical care improved a bit, maybe even outcomes in terms of hospital admissions improved, and maybe inequality was reduced. That all sounds quite good. Were there any downsides? Well, first of all, did the GPs cheat? Okay, so these are the reasons that GPs could exclude patients, and this was one of the ways at which we could look whether GPs cheated or not. And if we look at the rates of exception reporting in the first 5 years of the contract, you'll see that there are around 5% of patients excluded. Is that all right? Yeah, seems not too bad, does it? So, on the whole, I was quite pleased with that, really, because I thought it vindicated the GPs. However, if I put the bottom half of this table in, you can see the range. And in the first year, there were some practices that excluded no patients, probably because they didn't know how to. And one practice that excluded 86% of all its patients. So we have had an inspection regime, I have to say not a very effective one, but you can see that gradually the top figure is going down. But I think there's still serious questions about practices which think it's okay to exclude as many as 19% of their patients. Now I want to talk about some perhaps more interesting effects, which were the unintended consequences. Because Fred has told us that there's no such thing as a perfect drug. All drugs have side effects, all interventions have side effects. So let's talk about some of the side effects of this scheme. And the first and perhaps the best example relates to access to GPs. Now, before the Quality and Outcomes Framework was brought in, there was a real problem with getting access to GPs. Patients were waiting a week, sometimes 2 weeks, to get an appointment with a doctor. So an indicator was introduced that patients should be able to see a doctor within 48 hours. Sounded a good idea? The response of the doctors was to introduce a system sometimes called advanced access, piloted in the United States, that essentially would offer unlimited appointments on the day, so nobody would have to wait, anybody could be seen on the day. But many practices operationalized this by saying that patients could only be seen on the day and were unable to book ahead. So they achieved the targets, but patients found it harder to get appointments. And everybody knew this was happening, except one person. I want to show you a little video clip which shows our last Prime Minister, but one, Tony Blair, and this is a demonstration of why politicians are extremely reluctant to do live television broadcasts.